Bridge, Wikipedia article audio. A bridge is a fixed dental restoration used to replace one or more missing tooth by joining an artificial tooth definitively to adjacent teeth or dental implants. A bridge will span the area where teeth are missing. They are attached to the natural teeth or implants that surround this space. The natural teeth or implants which support the bridge are called abutments. Depending on the type of bridge, natural abutment teeth may be reduced in size to accommodate the bridge to fit over them. An impression will be taken of the abutment tooth or implant in space to provide a mold to create the bridge. Using this, the bridge is then fabricated in a dental laboratory. Definitions: Case selection and treatment planning. Fixed bridge, a dental prosthesis that is definitively attached to natural teeth and replaces missing teeth. Abutment, the tooth that supports and retains a dental prosthesis. Pontic, the artificial tooth that replaces a missing natural tooth. Retainer, the component attached to the abutment for retention of the prosthesis. Unit, pontics and abutment teeth are referred to as units. The total number of units in a bridge is equal to the number of pontics plus the number of abutment teeth. Case selection. Appropriate case selection is important when considering the provision of fixed bridge work. Patient expectations should be discussed and a thorough patient history should be obtained. Replacement of missing teeth with fixed bridge work may not always be indicated, and both patient factors alongside restorative factors should be considered before deciding if providing fixed bridge work is appropriate. The survival rate of bridge work can be affected by the span of bridge needed, the proposed position of the bridge, and the size, shape, number, and condition of planned abutment teeth. Furthermore, any active disease including caries or periodontal disease should be treated and followed by a period of maintenance to ensure patient compliance in maintaining appropriate oral hygiene. Multiple factors influence the selection of appropriate abutment teeth. These include size of potential abutment tooth, with larger teeth having an increased surface area preferable for retention, using teeth with a stable periodontal status, favorable tooth angulation, favorable tooth position, and an adequate crown-root ratio. Selection and evaluation of abutment teeth. Previously, Ante's law, which states that the roots of abutment teeth must have a combined periodontal surface area in 3 dimensions that is more than that of the missing root structures of the teeth replaced with a bridge, was used in bridge work design. However, research has shown no evidence supporting Ante's law. Conventional bridges are bridges that are supported by full coverage crowns, 3/4 crowns, post-retained crowns, onlays and inlays on the abutment teeth. In these types of bridges, the abutment teeth require preparation and reduction to support the prosthesis. Conventional bridges are named depending on the way the pontic is attached to the retainer. A fixed bridge refers to a pontic which is attached to a retainer at both sides of the space with only one path of insertion. Indications for use of fixed prostheses in replacement of missing teeth. A cantilever is a bridge where a pontic is only attached to a retainer only at one side. Contraindications for use of fixed prostheses in replacement of missing teeth. The pontic and retainer are remote from each other and connected by a metal bar. Usually a missing anterior tooth is replaced and supported by a posterior tooth. Types of bridge. The pontic is firmly attached to a retainer at one end of the span and attached via a movable joint at the other end. A major advantage of this type of bridge is that the movable joint can accommodate the angulation differences in the abutment teeth in long axis, which enables the path of insertion to be irrespective of the alignment of the abutment tooth. Conventional bridge. An alternative to the tradition bridge is the adhesive bridge. An adhesive bridge utilizes wings on the sides of the pontic which attach it to the abutment teeth. Abutment teeth require minor or no preparation. They are most often used if the abutment teeth are whole and sound. 1. Tooth preparation. This should be completed with reference to radiographs and study casts obtained during treatment planning. For conventional bridges, tooth preparation should aim to conserve tooth tissue, ensure a parallel path of insertion, achieve clearance in the occlusion and ensure well-defined preparation margins. The taper of each preparation on the abutment teeth must be the same. This is known as parallelism among the abutments and allows the bridge to fit onto the abutment teeth. Adhesive bridges require minimal preparation. 2. Master impressions. An accurate impression should be made of the prepared teeth, along with an impression of the opposing arch. The master casts are used to provide accurate information about the occlusion to the laboratory and construct the prosthesis. Fixed bridges. 3. Occlusal registration. An occlusal registration is needed when providing extensive bridge work to allow the opposing casts to be related accurately. This may not be necessary if only a small number of teeth are to be restored. Cantilever. 4. Temporary restoration. Temporary restorations should be fabricated if possible to protect and maintain the prepared teeth until placement of the final restoration. 5. Try-in. Confirm the clinical acceptability before cementing definitively. Assess the prosthesis on the master casts and identify the cause of any problems if present. A period of temporary cementation to assess clinical acceptability prior to definitive placement is sometimes used. 6. Final placement. Once satisfied the prosthesis is clinically acceptable, cement and bond the bridge work definitively. 7. Review. Assess the bridge work and manage any post-operative issues. Spring cantilever. Fixed movable. Adhesive bridge. Types of pontic. As with single-unit crowns, bridges may be fabricated using the lost wax technique if the restoration is to be either a multiple-unit FGC or PFM. Another fabrication technique is to use CAD/CAM software to machine the bridge. As mentioned above, there are special considerations when preparing for a multiple-unit restoration in that the relationship between the two or more abutments must be maintained in the restoration. That is, there must be proper parallelism for the bridge to seat properly on the margins. Sometimes, the bridge does not seat, but the dentist is unsure whether or not it is only because the spatial relationship of the two or more abutments is incorrect, or whether the abutments do not actually fit the preparations. The only way to determine this is to section the bridge and try in each abutment by itself. If they all fit individually, it must have simply been that the spatial relationship was incorrect, and the abutment that was sectioned from the pontic must now be reattached to the pontic according to the newly confirmed spatial relationship. This is accomplished with a solder index. The proximal surfaces of the sectioned units are roughened and the relationship is preserved with a material that will hold on to both sides, such as GC pattern resin. With the two bridge abutments individually seated on their prepared abutment teeth, the resin is applied to the location of the sectioning to re-establish a proper spatial relationship between the two pieces. This can then be sent to the lab where the two pieces will be soldered and returned for another try-in or final cementation. Dental bridges offer several advantages. They can usually be completed in only 2 dental appointments, restore the tooth back to full chewing function, require no periodic removal for cleaning, have a long life expectancy and are aesthetically pleasing. 1. Poor oral hygiene. As with any fixed prosthesis including bridges, maintaining good oral hygiene to prevent plaque formation around the bridge is key. This will ensure prolonged performance. 2. Mechanical failures. These failures can occur due to loss of retention of the bridge due to improper cementation, construction, or preparation. Fracture of the metal coating or pontic can also lead to mechanical failures. 1. Wash-through pontic. 3. Biological failures. These can occur due to caries in the tooth or due to pulpal injury. Problems with abutment teeth such as tooth fracture, secondary caries, or periodontal disease can cause discomfort and put pressure on surrounding soft tissues to also cause a biological failure of the bridge. 4. Aesthetic failures. These can occur at the time of cementation and include color mismatch, roughness of margins or improper tooth contour. Aesthetics failures can also occur over a period of time including through wear of teeth, gingival recession, or drifting of teeth. 5. Problems with abutment teeth. Abutment teeth affected by secondary caries, vitality loss, or periodontal disease can all lead to bridge failure. 2. Dome pontic. 3. Ridge lap pontic. 4. Modified ridge lap pontic. Bridge failures result in clinical complications and patients can present with eye pain in the oral cavity, 2. Sensitivity, bleeding and inflammation of the gums, 3. Foul breath and taste disturbances. Management of bridge failures depend upon the extent and type of failure, and these can be prevented through forming a thorough treatment plan with the patient as well, regularly emphasizing the importance of maintaining a very good level of oral hygiene after the bridge has been placed. The importance of cleaning underneath the pontic, through the use of interdental cleaning aids, should also be reinforced as plaque control around fixed restorations is more difficult. 5. Ovate pontic. Management options include keeping the bridge under observation/review, 2. Repairing, replacing, or removing the fault. Clinical stages of bridge work. Restoration fabrication. Advantages of bridges. Bridge failures. Common reasons for bridge failures. Oral manifestations of bridge failures. Bridge failure management.